Thank you for joining the JFNA Center for Advancing Holocaust Survivor Care's webinar, Emerging Issues in Aging and Trauma, Challenges and Implications for Person-Centered Trauma-Informed Care. My name is Leah Miller, and I'm the Associate Director at the JFNA Center for Advancing Holocaust Survivor Care. So on this webinar, we're going to first give you an overview of JFNA Center for Advancing Holocaust Survivor Care and our work in the field of trauma and aging. And then we'll hear from experts about emerging issues in aging and trauma and how you can implement trauma-informed care in your agencies, including how to address sleep issues and substance misuse. There will also be time for Q&A. So why is the center hosting this webinar? So on a recent call with my colleague Avital Merzon, the Holocaust Survivor Program PCTI Director at Ruth and Norman Rails Jewish Family Services in Boca Raton, Florida, I heard about her client Yelena. And Yelena is a Holocaust survivor from the Ukraine. When Yelena was a kid, she almost died from typhus, a bacterial infection that spreads through parasites. It's common in places that are overcrowded and have poor sanitation, like ghettos and camps. Recently, she was diagnosed with cancer and started having anxiety attacks. They've gotten worse with the pandemic. Yelena now has trouble falling asleep and staying asleep for more than 2 hours at a time. Almost every night, she has nightmares about being sick and gets anxiety attacks. She has trouble telling the difference between what's happening now and her traumatic past. And this is very common among Holocaust survivors and other older adults who've experienced trauma. So we're focusing on the intersection of older adults and trauma because, next slide, please, 70 to 90% of older adults have experienced a traumatic event. Trauma can impact people physically, emotionally, socially, cognitively, and spiritually. The consequences can last a lifetime. So the changes experienced as people age can also be a trigger in and of themselves, such as retirement or decreased mobility, death of a loved one, a loss of purpose like raising children, or the inability to access coping mechanisms like exercise or reading small print. And all of these things can reignite trauma symptoms in older adults with traumatic backgrounds that may have previously been coping well. So this is such a prevalent issue that the United States Department of Health and Human Services Administration for Community Living awarded the Jewish Federations of North America's Center for Advancing Holocaust Survivor Care a grant to, one, develop innovative ways to provide person-centered trauma-informed care to Holocaust survivors, with the idea that what we learn from working with Holocaust survivors can later be applied to other populations of older adults who have experienced trauma. And two, to build the national capacity to provide person-centered trauma-informed based services to Holocaust survivors and other older adults who've experienced trauma. And we do this in so many ways. We've awarded over 100 grants over the past 5 years, and they range on topics between helping Holocaust survivors in their mental, physical health, socialization, technology, how to use it, cognitive health, and training. We also have a critical supports program that supports Holocaust survivors through a community-based system. Next slide, please. So we have actually, my colleagues, Barbara Bedney and formerly Michael Eisinger have come up with this term of art. Actually, it was created by the federal government, but they came up with the definition. And it's a holistic approach to service provision that promotes the dignity and strength and empowerment of trauma victims by incorporating knowledge about the role of trauma in victims' lives into agency programs, policies, and procedures. So really, you can apply this at any level that you're working at an agency. Everyone from the person who works in the parking garage to the person cleaning rooms, all the way to, of course, direct service providers and executive staff in coming up with policies. So one of the best ways to be person-centered trauma-informed, or I live in Washington, D.C., and we have a nickname for everything. An acronym for everything is PCTI, is to be mindful of the ways that a history of trauma can impact older adults. So Yelena remembers that only the healthiest survived the Holocaust, and those who were sick often had to be left behind or they were shot. So our goal today, in fact, one of the goals of the center, is to teach you ways to provide person-centered trauma-informed care to older adults like Yelena. So with that, I'm honored to introduce to you our speakers for today. We are lucky to have with us some of the leaders in the field. First, I'd like to introduce to you Dr. Joan Cook. She is an associate professor in the Yale School of Medicine, Department of Psychiatry. She has over 100 publications in the areas of trauma, stress, and geriatric mental health, one of which was published by Newsweek in the last week. Dr. Cook has worked clinically with a range of trauma survivors, including combat veterans, those who experienced physical and sexual assault, and survivors from the World Trade Center bombing. She's a member of the American Psychological Association Guideline Development Panel for PTSD and the 2016 president of APA's Division of Trauma Psychology. I'd also like to introduce to you Dr. Joseph Ruzek, who retired as a director of the Department of Veterans Affairs to the National Center for PTSD Dissemination and Training Division in April 2018, after providing PTSD services in the VA for over 26 years. He really was a leader in the forefront of this topic. Dr. Ruzek is an adjunct professor at Stanford University, Department of Psychiatry and Behavioral Sciences, co-director of the Center for M2 Health at Palo Alto University, and a professor in the Department of Psychology at University of Colorado Springs. I am really glad that they made time for us today with all that they have going on in their worlds. There's just a few housekeeping things that I want to take care of before I hand over the mic. First of all, because there are several hundred participants. In fact, we have over 250 people logged in right now. We have muted all of your lines. However, we really do want to hear from you, and we encourage you to ask questions throughout the webinar in the QA box at the bottom of your screen. Our experts will respond to your questions at the end of the webinar and maybe even throughout. The webinar will be recorded and it will be posted on our website, and we'll be glad to share with you the PowerPoint that Dr. Ruzek and Dr. Cook have presented. So with that, at the end of the webinar, which is scheduled for 3:30, a participation code will be shared for our subgrantees to prove participation. And with that, I'd like to hand the microphone over to Dr. Cook.
Thank you. Hi, everyone. I met some of you at the conference last year in DC. I'm happy to see, or not see, I guess. I'm happy to be with you again. When Barbara and Leah asked Joe and I to give this presentation, they really asked for very hands-on materials so that you guys could put more and more and more good stuff in your clinical toolbox. So Joe and I are going to speak for half an hour each. We both speak typically very loudly and quickly, but we'll hang around and answer any kinds of questions afterwards. Next slide, please. Thank you. So we're going to hit two main topics today. I'm going to talk about sleep disturbances, and in particular insomnia and nightmares. Again, we're not going to give sort of the epidemiology or talk more about the phenomenology. We're going to give you hands-on skills that you can use with the people that you're working with. And then Joe is going to talk about substance abuse. Next slide, please. So not to belabor this point, because Leah just said this, but why do we think this is really important? Well, there's a graying of America, more and more people, not only in the US, but in industrialized countries. We know relatively little, and certainly less, about trauma in older populations than we do about trauma in kids or adolescents or even young adults and middle-aged adults. And why do we think this is really important? Well, we think it's really under-recognized on the part of healthcare providers and on the survivors themselves. And that what happens is if they don't label it, these symptoms and signs of trauma-related distress, and if the providers don't see it, then they're getting treated for something else and undertreated for trauma related effects. And I know on this slide, I'm really preaching to the choir, which is why you're here. Next slide, please. So insomnia is a very prominent sign. Sleep disturbances are very prominent trauma-related mental health consequences. The effects of insomnia are very large, as all of you know. When a person has a difficult time sleeping and that becomes a regular occurrence, their ability to tolerate minor irritants decreases, their irritability increases, they have less energy and more fatigue, they're more restless, they have difficulties concentrating. People who have chronic insomnia, like some of the people that we all work with, older adult trauma survivors, they're then at an increased risk for a lot of medical health problems, including hypertension. It triples their risk for heart failure. They wind up having more medical problems. They're at an increased risk for using more and more and being prescribed more and more medications. We could talk a little bit about that in the Q&A. I did some research a number of years back on inappropriate benzodiazepine prescribing in older adults. And we can talk about that, the difficulties of getting providers to stop prescribing those on a chronic basis and to help older adults taper from those. And then people with chronic insomnia also are twice as likely to be hospitalized. So this is a big problem for older adult trauma survivors. Next slide, please. Thanks. So one of the first things you want to do, and I have inventories that I could share with Barbara and with Leah, and they can send them out to you, is to really take a good sleep history. And I can't emphasize this enough. So things you want to keep in mind as you're doing this, always be keeping in mind what triggered the insomnia, what were the precipitating factors, and what's maintaining it, what's the perpetuating factors. You want to find out about the nature of the sleep complaint, the real details. Is it the difficulty falling asleep? Is it waking up in the middle of the night and having a hard time going back? Is it early morning awakening? Is it all of the above? When did this first begin? What's been the frequency of it, the chronicity of it, and the pattern over time? Next slide, please. Okay, and you also want to find out about their typical sleep wake schedule. So what time do they typically go to sleep? How long does it take for them to fall asleep? How many times do they get up in the middle of the night? How hard is it for them to go back to sleep? What time do they normally wake up? And sort of see if this is different between the weekends and the work days. This might be less relevant, the weekends versus the weekdays, for the older adult trauma survivors, but certainly for people in the work, who are still in the workforce, this could be much of an issue. Find about how often they're napping, and find out about their total sleep time. I think you also need to find out, when you take a sleep history, about what is their daytime function like and what are the consequences of insomnia in their life. It's also important to find out about their circadian sort of tendencies. Not all of us are morning larks. Some of us are sort of night owls. So find out what's been their habit and their routine throughout their life. Find out about a family history of insomnia and sleep disorders. Next slide, please. And then this is something where I think non-prescribing mental health providers can really have quite the impact. So do a very thorough history on the behaviors and the sleep environment, because this is where we can have the most impact with cognitive behavioral therapy for insomnia, and we'll talk about that in a few minutes. So find out about their bedroom environment. What's the comfort like, the noise, the lighting? What's their bedtime routine? Do they watch TV in bed? We're gonna try to break those bad habits. Do they watch the clock? Are they using alcohol and nicotine shortly before bed? Do they engage in exercise, and what's their diet like? All of these can impact their ability to fall asleep and stay asleep. Next slide. And then also we want to find out about their sleep aids, the history of use, both prescription and over the counter, what's worked for them, what hasn't, what are the current medications. And a lot of times people like us who are non-prescribing mental health professionals, we can do this in a team, in an interdisciplinary team where we have people who that is their specialty. And I misspoke, it could be some of your specialties who are on the call. Find out if they're using alcohol for sleep and their interest in medication. I know some of the patients that I've worked with over the past have only said, I just want a benzodiazepine, just get me one, and that's it. And really our job is to really engage in motivational interviewing and getting our sort of foot in the door to get them to try these other non-medication treatments. It's important to get a history of other sleep disorders because they could have sleep apnea and need a CPAP machine. They could have narcolepsy or things along those lines that would need a different and additional intervention. It's good to take a medical history as well as a psychiatric history. Next slide, please. Okay, so what I'd like to spend some time talking about right now is CBTI, cognitive behavioral therapy for insomnia. It's been shown to be effective in a range of populations. It's sort of a go-to treatment. This is just an overview, and I'm going to go into 4 of these, not all 5. So one element, one component of CBTI is sleep restriction, where you want to help increase sleep drive, consolidate sleep, and maybe shift or strengthen circadian sleep-wake rhythms. Not going to review that today. If you are interested, I can certainly share that information with Barbara. What I am going to go over are the other 4 components: the stimulus control, where we want to stimulate the bed and the bedroom as sleep cues; arousal reduction, where we want to help people increase their relaxation, reduce their emotional distress; cognitive restructuring, where we address maybe some of their unhelpful thoughts and beliefs that may not only impact sleep, but with their adherence to CBTI or other interventions; and then good sleep hygiene, which are good sleep habits. Next slide. So, oh, sorry, one back. Yeah, thank you. So let's go over the stimulus control. The principle is the bed is for sleep and sleep is for the bed. And that's all that should be occurring. Now, in addition, I should have put on there that also the bed is for sleep and for sex, and that some of our older adults like to have sex, and that's okay. That's a good thing. But we try to break the associations with all the other things that might happen. So we want to find out if they're doing these things and then help them to break these habits and replace them with other healthy things. So we want to avoid sleep incompatible activities in bed, which some of our older adults do, especially if they're limited to living in one room and their TV is there. And that's where they, engage with all the world. So typically when we engage in stimulus control and even good sleep hygiene is we don't want sleep being done when people are in bed. So we want to break that association. Reading, paying bills, worrying or thinking. Some people, when they lay down their head at night, they worry about all the things that they have going on and plan for their day the next day. And we want to try to break those associations too. So avoid also sleeping outside of bed. We'll talk about this a little bit when we talk about napping. We want people to reduce their napping or even eliminate them. But if they do that, do not do it in the bed. To maintain a regular sleep schedule and only go to bed when they're feeling sleepy. I know that's hard for some people who say that they never feel sleepy. Next slide, please. So what we're going to try to teach people with CBTI is if you can't sleep, if you're unable to sleep, get out of the bed. We want to break that association. So if after 15 to 20 minutes, they're not falling asleep, they start to get aroused, get out of bed. And we really suggest to people to, try to spend 30 or 60 minutes engaged in some kind of relaxation activities. I'm going to share some of them with you here, including helpful free apps that they can use that have an evidence base for them. And really to get into bed, to get out of bed and then keep repeating that schedule, even if you have to keep getting out of bed. I know that can be difficult for some of our older adults who have mobility issues, and it really becomes more of the care provider to assist in that. And really to try to establish these new patterns and new routines, which oftentimes can take up to a month, but they do work if we don't quit. Next slide, please. So with sleep hygiene, the important is to really be consistent, to go to bed at the same time each night and try to get up in bed the same time each morning, get out of bed, and including on the weekends. Make sure the bedroom is quiet and dark and relaxing at a comfortable temperature. Remove all electronic devices, what I had said earlier with the TV, but that also includes smartphones. Avoid large meals, caffeine and alcohol before bedtime, and try, if they can, to engage in some forms of exercise. If the more they engage in exercise, that should help them to sleep more at night. Next slide, please. So we really want to help our older adults who have chronic sleep-related problems to minimize their napping. I think a lot of people think that napping helps them to catch up with their sleep, and it actually doesn't. If they insist on it, if we can try to encourage them to keep little naps outside of the bed and for only 30 minutes, and to avoid looking at the clock. I tell the people that I work with, actually take the clock out, or if you don't feel comfortable taking it out of your bedroom, at least turn it around when you go to sleep, so that the thing is, if you turn over to look at it, it's not there for you to see. It's got its back to you. Next slide, please. Okay, and then we also teach them in conjunction. I don't think any one of these skills sort of works. It's important to teach them all of them and to have them practice on a regular basis. Otherwise, when they reach for them, those tools will not be theirs and be available. So a number of arousal reduction or relaxation therapies include progressive muscle relaxation, which many of you likely know and use, deep breathing exercises. They could also be getting massages or meditation or yoga, or any healthy, safe relaxation strategy can be effective, and also potentially multiple ones. Next slide, please. Okay, and I think that this is sort of an unrecognized component or underutilized component, is really focusing on the role of the thoughts, the unhelpful thoughts that are happening in people's minds all about sleep and the effects of not getting enough sleep. And so some people say, like, I just can't shut my mind off. And while that may be true, it may be difficult to turn off your mind, to help them say things a little bit differently. So I understand that it's hard. It's been difficult for you, but you can learn a way to do it. And it's also hard if you're thinking about and planning for the next day and you have all these sort of anxieties and worries. That also should not be happening before you go to bed. So we need to address that. Worried about being able to get to sleep and worried about the consequences. So we need to help them change their thoughts about that. Next slide, please. So here are just a few dysfunctional, is probably not the best word, but unhelpful beliefs and attitudes, like, oh, there's little I can do to improve my sleep at my age, or without a good night's sleep, I just can't function, or I need 8 hours of sleep at my best. Napping helps me to catch up. I just can't sleep without medication. And I understand that these are very common and that our older adult patients say them, but they're not very helpful. In fact, they will continue to promote them engaging in anxiety and worry and not getting good sleep. So I'll help tweak these in a few minutes. So we want to challenge these gently and have them take an inventory of them. Next slide, please. One way to do that, if people have a difficult time, doing daily thought records or things, is to give them this personal beliefs and attitudes about sleep scale. And I can send that to Barbara, and she could send that out to folks. Next slide, please. So we work just like we do typical, a la Beck and CBT, is we just work on helping to sort of massage and make those thoughts a little more palatable. So teach them to identify what are the thoughts that might be getting in their way of initiating sleep or staying asleep, and then help them to challenge those beliefs, the accuracy of them, and coming up with, even if it's slight alternatives. You guys all know about, sometimes we just want to get our foot in the door to help sort of change with people's unhelpful thoughts. Now, sometimes changing these beliefs about sleep can have reverberating effects, positive, for other aspects of their trauma-related symptomatology. And next slide, please. So here's just slightly tweaked, right? They're not horribly different, they're somewhat different. There are small things I can do that can improve my sleep quantity and quality. Sleep experts say that most adults need between 7 and 9 hours of sleep for optimum functioning. Napping will not catch me up for a sleepless night. while alcohol may calm me and speed the onset of sleep, it actually increases the number of times I'll awaken at night. So these are sort of challenging the unhelpful thoughts or the myths that older adults and regular adults may have about sleep. Next slide, please. Sometimes it's really helpful for our older adults who have a lot of things they want to process, a lot of worry in their minds, to set a time throughout the day, 15 to 20 minutes, a half an hour, to write down all the worries or to talk about all their worries so that less of it comes up at time. And this can, you know, reduce their need to sort of go over it in their mind at night. Next slide, please. So something that Joe and his team developed at the National Center for PTSD, this is a free web-based app, that was developed at the National Center in Stanford and the Department of Defense. It's called PCTI Coach. And it really entails all of what I just told you, that sort of you can help them. It could be your little cheat sheet in helping them, and then that they can use it themselves. And it's free. But it has, you know, tools to help improve sleep and psychoeducation. I'm just going to show it to you next. Next slide. And I think you have to hit it several times to get them all up. I apologize, I should have taken that off. But it really is all of the components of CBTI there at your fingertips for free to help you help your patients implement this. Next slide, please. And then there are other apps that also work very effectively in helping people to reduce the arousal. So there's a great app called Mindfulness, and there's another one called Breathe to Relax. These are ones that people are widely sort of using. There's some evidence for their support, and they are empirically what you would call promising. Next slide, please. Okay, so I'll talk just briefly about post-traumatic nightmares. I've had 2 randomized controlled trials that I've been at the helm on in terms of post-traumatic nightmares. These are very difficult things to treat, as you know, and sometimes when we use those other evidence-based psychotherapies that we have that you all know about, like prolonged exposure and EMDR and cognitive processing therapy, sometimes we use those and our patients get significantly better, but it doesn't help with the nightmares. And so a number of colleagues around the country and I have sort of studied on how do we treat those. Post-traumatic nightmares involve really frightening, distressing dreams that are often related to the traumatic events. Sometimes they're exact replays. For the trauma survivors that I've used nightmare rehearsal with, they've been mainly combat veterans and former prisoners of war, and they oftentimes have exact replays of the trauma. Sometimes they're symbolic of the trauma, where they're not exact replays, but they're sort of like feelings or situations that remind them of it, and sometimes there's a mixture. One of the things about nightmares is that they often wake the dreamer, and then the dreamers are so aroused and distressed, they have a difficult time getting back to sleep. Next slide, please. And nightmares are also associated with significant distress and daytime impairment, occupational and social functioning. They increase people's depression. They have difficulties concentrating and focusing their attention. They're oftentimes one of the most frequently reported and distressing symptoms of PTSD. Next slide, please. So why do we sometimes treat these differently? Well, people oftentimes come in with this complaint, whereas they have a harder time labeling that they have PTSD or depression, but they'll admit or acknowledge presenting with nightmares as a complaint. These are often, as I said a few minutes ago, resistant to the evidence-based psychotherapies. Resistance is probably not the right word. They're more difficult to treat. So they can be somewhat impactful in reducing the frequency or in the intensity of nightmares, sometimes the distress, but oftentimes we need a supplement. Sometimes these can also be, nightmares can be sort of an entry point for us then going on to do future, more broader, comprehensive trauma-informed treatment. Next slide, please. So a number of things that people are using, they're using relaxation strategies. That in and of itself doesn't seem to be helpful. CBTI has been somewhat helpful. What people have been doing in addition to exposure, prolonged exposure, cognitive processing therapy, EMDR, is something called nightmare rescripting. And this is the treatment that I have studied, and I can send you those randomized controlled trials. There are a number of different ways to do this treatment. It's called imagery rehearsal therapy. Next slide, please. So in a nutshell, what it typically is, even with the different bells and whistles that the different groups use, is there's a formal sort of component of exposure to it, where you write out the content of your nightmare, or if you're no longer able to write, or your provider will help you do that, you would help your patient do that. Then we want to help them re-script it. This has been something that's been very difficult for the combat veterans that I've worked with, because they say to me, Joan, you're trying to change my memory. And I say, I'm absolutely not trying to take away your memory. And with the other trauma processing therapies, you're helping them to digest the memory, make sense of it. I'm not even trying to do that. I'm just trying to help you get a better night's sleep. So try to re-script it so that it no longer culminates in a distressive ending, and they no longer get so aroused. We'll talk about that. It's somewhat promising in other populations. It's been shown to be effective in female survivors of sexual assault. My colleagues and I at the University of Pennsylvania, we studied it with Vietnam veterans. We used it as a group modality, and then we studied it in veterans coming back from Iraq and Afghanistan. We used it in an individual modality. It's a good supplement. It's a good thing to have in your toolbox. It's not necessarily going to do the trick. I have never seen any studies of it, or even case studies of applying of it with Holocaust survivors. Next slide, please. So essentially, as I said earlier, you identify a recurring nightmare. If you have multiple nightmares, you ask the patient which one they feel most comfortable choosing. Typically, the patients that I've worked with have chosen the more distressing. Some of those randomized trials that show that imagery rehearsal is so effective, I think, if I'm interpreting it right, they're picking the less distressing nightmares. And some of the patients don't have full-blown PTSD, and I think that's the difference between their trial and ours. You want to brainstorm all the possible ways of changing the nightmare. I'm going to talk about that in the next slide, but what you essentially want to do is help the person pick a strategy that will work for them, because if it doesn't work for them, they're not going to practice it, and they need to practice it, not only before they go to bed, but throughout the day. Next slide, please. So typically, imagery rehearsal, I can even send you the manuals that we use, or 5 to 6 sessions. It's an introduction and rationale. It's a write out of the nightmare. It's a brainstorming. It's the re-scripting, and then a tweaking of it. When you write out the target nightmare, it's good to use the present tense, use as much sensory detail as you possibly can, use beginning and end points. Next slide. So this is where the group therapy for imagery rehearsal does become helpful, because the more minds you have brainstorming these ideas, the better. But I think there's some downsides to doing it in group, which we could talk about. So one way to change the nightmare is to identify alternate endings in the dream. So a number of veterans that I've worked with over time, there's a lot of fear of dying and life threat, where they feel like, you know, I almost just died, or I'm going to die, and to sort of put in a different ending. And whether that's sort of like, you know, if it's a firefight and there's sort of like, you know, gunfire, to sort of changing that to it's sort of an explosion with a star-filled sky, or inserting reminders of how that you survived. So for some people, it's putting people in, like if you went to combat and you weren't married and now you are married, inserting your spouse or inserting your children into your nightmare so that you know, you give yourself your message that you survived. Transforming threatening weapons or threatening objects. I know these sound wild and wacky, but they can sometimes work. Sometimes if a patient says to us, you know what, I don't want to change this. I want to be faithful to this memory. This is how it happened. I know you just want me to help me get a better night's sleep, but I don't want to change this. Then we say, just try to distance it. Picture if it's like it's on a TV screen, or you're watching it, or you're the director, you know, sort of directing it, or turn down the volume, or turn down the vividness of the color. And any other kind of like, it's only a dream reminder, try to insert that in there. Next slide, please. And so the general guidelines is do what works for your patient. If they only want to try a mild different ending, that's great, or a distancing technique, or wild and wacky, whatever they feel comfortable with trying. The point is to sort of practice it over time. Try to match it in detail and length with the nightmares. and try to end with a scene of relaxation where they feel comfortable, competent, and in control. My colleagues and I did a number of studies where we looked at what were some of the dream contents and what were some of the themes. And the patients that we helped them make an ending where they felt more in control had more significant reduction in their nightmare frequency, intensity, and distress. So if you can resolve the nightmare theme and exclude the violence, it's more apt to work. And then you have to practice it over and over again throughout the day and right before going to bed. Next slide. And that's all I've got for now. See you in the Q&A.
Thank you, Joan. And hello, everybody. And I appreciate very much the opportunity to be with you today and to speak with you. I want to talk a little bit about something that is also a problem in our older adult populations, particularly those who have experienced trauma and or developed PTSD symptoms across their lifetimes, and that's problem drinking. Next slide, please. So, as I'm sure you know, problem drinking is a common problem amongst older adults. It's true that most older adults are drinking less alcohol and less often than older adults, but many do suffer from alcohol-related difficulties of different kinds, either severe long-term problems or more near-term difficulties that have to do with drinking to cope. The earlier onset problem drinkers make up the biggest group. These are individuals who have actually had alcohol consumption difficulties across the lifespan. They developed it as younger persons and then continued it into their older adulthood. In this sense, it's sort of a long-term habit that they've developed as a coping tool that may have led to difficulties and created negative consequences in many areas of their life. The earlier onset drinkers, who we would define as having started their drinking and developed problems before the age of 60, occur to the majority of problem drinkers in older life, about 2/3 of them. Next slide, please. There is a third, however, that have developed their alcohol-related problems later, after age 50, with the onset. And these people are less likely to show many of the major consequences of long-term drinking problems. For example, all kinds of health problems, liver cirrhosis, and also are less likely to be troubled by more severe mental health difficulties. And by virtue of the later onset, their drinking has created less in terms of the cumulative negative effects that have taken place. So they may well have more intact relationships with their family and friends, which may have been really hit hard by the people who've been drinking across their entire lives. The later onset problem drinking is often linked to stressors associated with the transitions of getting older, the increased free time, the maybe social pressures to drink, which might happen later in life, the loss of a spouse, the physical and cognitive deterioration that many of us experience as we get older, the difficulties in the transition to retirement, and the social isolation, relative social isolation, which comes with getting older. And you'll notice in a minute, I'll talk about the ways and the factors that impact the the worsening and the improvement in PTSD symptoms amongst trauma survivors across a lifetime, and you'll recognize these same kinds of stressor events. Next slide, please. So we do see a very strong relationship between alcohol consumption and PTSD, alcohol problems and PTSD, and indeed all substance abuse problems and PTSD. People with PTSD are much more likely and to develop alcohol or other drug problems. And here you can see some of the numbers. So almost 50% of individuals with lifetime PTSD also have met criteria for substance use disorder at some point in their lives. This is true of women, with numbers around 28%, and even more so of men, exceeding half. So this relationship has been observed across the years. We see it not only when we look at subsets of individuals with PTSD and look at their rates of substance abuse problems, But we also see it the other way around. When we look at samples of people who are misusing substances, we find higher than ordinary rates of PTSD in those individuals. And there are three main concepts that underlie this close relationship between PTSD and problems with substances. One is that there may be aspects about the individual or about their environment which are independent and have caused both PTSD and alcohol misuse. So these can be genetic vulnerabilities of personality types, and also, being subjected to the very disruptive, difficult environments in childhood, which can then both lead people to develop anxiety disorders, but also lead them to turn to substances as a way of coping. It is also true that individuals with alcohol problems may expose themselves to environments which are more troublesome. So, people that use alcohol excessively are more likely to get into car accidents. They're more likely to be sexually assaulted because of, the interpersonal environments they're getting into, and the fact that they're not as in control of their own behavior and kind of picking up on safety cues. And also, withdrawal from alcohol, it creates a lot of sensations and physical symptoms that can mimic PTSD symptoms, and so that withdrawal can actually exacerbate PTSD. But the major dynamic that we think is going on is that PTSD symptoms can wind up causing the development of heavy drinking. In fact, when we look at individuals who have both problems, and we do timeline follow-back interviews, it's usually the case that alcohol consumption got heavier after the development of PTSD. So that gives us a cue or a clue that people have developed PTSD, and then they've turned to alcohol as a way of actually coping. It's called the self-medication hypothesis. People are learning over time to self-medicate their PTSD symptoms. This happens because, when people get PTSD symptoms don't just sort of naturally remit in easy ways, in the ways that we, by virtue of the ways that we use to cope stress, by relaxing, by being with friends, by distracting ourselves with TV. They're more difficult to remediate. And so over time, people are likely to give up on ordinary coping methods and turn to excessive alcohol consumption as ways of managing their own symptoms. Next slide, please. So in fact, PTSD symptoms are not things that once you develop them, they stay constant across your life. They ebb and flow. There are periods of PTSD symptom worsening, periods of somewhat improvement. People may have levels of PTSD symptoms occurring all the time, but they may occur with greater intensity or greater frequency at different points in time, such that, in fact, people that meet criteria for PTSD at point A may not meet criteria for PTSD a year later at point B, and later at point C, 5 years later, they may meet criteria for PTSD again. It fluctuates, and a lot of age-related factors do affect the fluctuation of PTSD symptoms. And you'll notice these are the same things that are some of the stressors that can lead to excessive alcohol use in older adults. The increased risk for medical illness, which comes along with age, tends to exacerbate PTSD symptoms and also may lead to self-management through alcohol consumption. Declines in functioning, the bereavement that we experience the more likely to experience as we get older, the retirement challenges, which also involve more open time and more time for reflection. Many people with PTSD have been workaholics. They've jammed their transmission in their life by excessive activity levels, and that's been a way of coping. Retirement disrupts that. Changes in social and familial roles, and just generally the feeling of loss of control that can co-occur with aging. Next slide, please. So I think we heard from Yelena, the case of Yelena that Leah put forward was a great example of how COVID can actually act as an exacerbator of both PTSD and alcohol misuse. And I think that Yelena exhibited both increased panic and anxiety symptoms, more intrusions in remembering the trauma and experiencing reminders, and also disrupted sleep. So it's a good example of how COVID can come in and act as a trauma reminder. Some individuals are haunted by memories of having to quarantine when they were moving countries before resettling in Europe or in the United States. Therefore, that can be a reminder of trauma for them. The news coverage that we're seeing in the United States of the medical supplies shortages, you know, the lack of access to masks and so on, the cities being overwhelmed. I was in Brooklyn, New York for 3 months of the coronavirus, and you know the news coverage there was how the morgues were being overwhelmed and there were not ability to store the dead bodies in the hospitals. That can be reminiscent of lack of medical care and other stimuli during the Holocaust. That brings up those difficult memories. And also sickness, as Leah mentioned, sickness was a very bad thing because, you know, people that were sick were likely to be, you know, carted off and killed. So illness is equated with death. And so all of this stuff in the society, all this heightened awareness of illness and sickness, all of those things can actually directly elicit memories of the Holocaust. And for other kinds of trauma, they also they can exacerbate PTSD symptoms. So we're in a situation that PTSD symptoms may interact with and be worsened with COVID experiences, and as well as the ongoing stressors associated with aging. And that increased PTSD symptoms and other symptoms of depression and anxiety may increase use of alcohol to cope. Next slide, please. So I want to quickly talk to you about 3 sort of pragmatic tools that you can use to do things that will reduce the likelihood that a person will be drinking heavily to cope with all this stuff. And first, I'm going to talk about self-medication triggers and identifying those. And I'm going to talk about some very straightforward ways you can strengthen people's social support and lift their mood by getting them involved in participating in more positive activities. Next slide, please. So I mentioned the self-medication hypothesis, but at some level, it's a very broad idea, right? People are self-medicating to deal with their distress. So one thing that I just want to make you aware of is you're a sort of detective here, and people don't just self-medicate generally. They often are also self-medicating very specific kinds of difficulties or symptoms. So one thing for you to do as a detective is try to kind of get an idea for what 2 or 3 special sources of distress the person may be turning to alcohol or other drugs to reduce. So that can help you because, you know, then your coping skills that you train a person in can map better onto the source of distress and have more likelihood of helping the person. And also it helps you to think about how you might intervene to change aspects of their environment, which may be a problem. So a great example is Joan, Dr. Cook, has talked a lot today about insomnia and sleep difficulties. So if in fact your individual is self-medicating sleep problems, which is extremely common, then you can select coping skills, AKA the different arousal reduction strategies that Joan talked about, as well as PCTI for insomnia. And also you can look at their environment. So, you know, you can intervene in the way they've set up their sleep environment, make sure it's more conducive to sleep and so on. But if the trigger is something else, like for example, you know, just heightened arousal generally, then you might focus on anxiety reduction methods. If it's physical pain, you might focus on pain management methods. Next slide. So here's my slide saying what are the common triggers for trauma survivors that might lead to medication use or drug use and alcohol use. And they are sleep problem and pain problems, which are categorized here as sort of physical or health concerns, low mood, depression, the social aspects that are related to depression of interpersonal loneliness or relative social isolation, and then also certain kinds of PTSD symptoms. And the big PTSD symptoms, which are often linked to self-medication, are anxiety and hyperarousal, because people want to calm themselves and they turn to alcohol to calm themselves. And also intrusive memories, when people are remembering their experiences or being triggered with things that make them recall aspects of their own personal traumas, they have those intrusive memories. The intrusive memories are extremely unpleasant, and they may want to blank those out or interfere with them by drinking and sort of knocking themselves out. Next slide, please. And here you can see an example of how we might use our assessment of what our particular trauma reminders or trauma triggers and map them onto the coping skills we might teach people. So, for sleep, we might turn to CBT. For insomnia, pain, there are established pain management methods that we can use. For depressed mood, we might turn to behavioral activation, AKA known as getting people to involve much more actively in activities that lift their mood. I'm going to discuss that in a moment. For loneliness and social isolation, you want to rebuild and support their social connections, social support. I'm going to talk a little bit about that. For PTSD symptoms, if there's a lot of anxiety and hyperarousal, we want to look at all the different kinds of methods of anxiety management, which are the calming physical relaxation methods, but also the cognitive therapy methods, looking at what people are saying themselves and make themselves experience anxiety and so on. And for intrusive memories, that's where I think we want to especially bring in the trauma-focused psychotherapies if we can, because they are especially targeted at reducing the memory intrusions which create problems, and including the trauma-related intrusive dreams that Joan has discussed a little while ago. Next slide, please. So I've just mentioned this, but also for symptoms of arousal, if the symptoms of arousal are overwhelming for a person, there's also a whole host of tools that we call grounding tools that can help people who are being overwhelmed by strong emotion stay present. And those, and if you probably know about those, but if you Google them, you'll see different kinds of ways of helping people focus on immediate aspects of their environment to control their attention and move them off of the trauma stimuli onto immediate, touch and smell and other stimuli in their immediate environment. For the intrusive memories, that's where we want to try, if we can, to find ways of getting people access to prolonged exposure, cognitive processing therapy, and EMDR interventions, which are more effective than other psychotherapies in both treating PTSD and also reducing intrusions. And if you are able to learn these psychotherapies and add them to your repertoire, we really recommend that. But also simply finding somewhere in your environment, this can take some work, but locating mental health professionals who are competent in these things is a very good idea for you to be able to refer, just as you need to refer for specialist alcohol or drug treatment if you see someone who's got a longer term difficulty with these things. Next slide, please. So I want to talk real quick about how you can build stronger social connections with people. And this is something I'm sure you do in your work, but I'm going to kind of orient you to a tool that we found very helpful to launch these conversations with your clients. Now, this is important because for a whole lot of reasons. Social support is really something that I don't think we tackle as carefully as we need to in working with trauma survivors and those with PTSD. This is despite the fact that if you look at all the studies of PTSD, the development of PTSD after traumatization, and also recovery in PTSD, we always find that social support is a very strong protective factor. And it's a protective factor both for stress management, but for alcohol consumption, alcohol recovery, and PTSD recovery. Now, positive support is a big deal, but also it turns out in PTSD, an even bigger deal is bad support. So if you have people that blame you for your trauma, this is especially common, for example, in female sexual assault survivers for whom people in their life may blame them for having put themselves in a position for being experienced a sexual assault. Or, you know, in the military, we've too often found that female military veterans, once they attempt to report their social support, you know, get berated and treated badly by leadership, and that exacerbates PTSD and makes it worse. So our ability to both enhance social support and reduce negative social support is very important. PTSD is also related to social support in that having PTSD and also having some other mental health problems like depression can sometimes worsen social relationships. So an individual with PTSD is likely to be irritable and angry. And that means that they may be difficult to get along with at different times. And so over time, their ability to recruit social support and form good social relationships with their peers can worsen. Also, they may experience social numbing. One of the #1 complaints in marital relationships of individuals with PTSD is that the person with PTSD is not giving off the positive vibes and not saying, I love you. They're not expressing nonverbal love in the way that they would if they did not have PTSD. So we want to pay attention to that. And basically social support of all kinds is a major coping tool and reduces the impact of the current stressors and all the stressors that people are likely to be experiencing in older age. Next slide, please. So the building social support and strengthening social participation and social connections should really be a specific target and a sustained target of treatment and support for older adults who have experienced trauma, and especially those who are also misusing alcohol. And you know, that means that you know, we want to really pay attention to make sure that we are doing everything we can to deepen and strengthen and increase the frequency and quality of the social participation and social relationships that our clients have. And we want to build in, if we are seeing them on a regular basis, build in regular therapeutic assignments that make sure that people are seizing the opportunities for social connection and that they're getting the most out of those. So I'm going to describe to you just a very simple tool for launching conversations with clients about this. It's called a social connections map. And this was developed in work that I and colleagues did in trying to develop brief, effective interventions for disaster survivors. So you can get an entire manual on this stuff, and you'll find a whole lot of materials on the social connections map. It's called Rebuilding Social Connections by going to this website, www.ptsd.va.gov. It's the website, it's the premier website in the world for PTSD, run by the National Center for PTSD. I can say that because I didn't develop it, although I've contributed materials there, but go on there, find the manual for skills for psychological recovery, and you'll find a whole bunch of very pragmatic materials for how to do this next exercise that I'm going to introduce you to. Next slide, please. So this first step is to get the person to develop a social connections map. Now, I love this because it's much more engaging for a person, right? Because if you get them to sit down and kind of make a visual map of their social world right now and their social connections and who they like, who they hang with, who they have telephone calls with, that's a great way of launching this conversation. It's more engaging for a person. You're going to help them complete the map. And also in doing this, you're going to be reviewing what they're experiencing, what they think of their map, and you're going to be seeking to enlarge their thinking about who else can they add to that map? Are there people that they can add, that they can access at a distance? Maybe there was somebody they went to school with that they really loved hanging out with, and they really haven't been, you know, contacted in many years. They dropped off, or maybe they talk to them now, but it's only one telephone call at Christmas per year, and they could really thicken that relationship, that person would probably welcome them on the phone. People they used to know, and also especially community opportunities, community organization, community settings that cater to older individuals and can offer a lot of much more rich opportunity for social participation. So this social connections map enables people to step back, take a big comprehensive look at what their social network looks like, you know, what's not there, but also we want to focus them on who is there, because we realize that they will have had a lot of losses across the year. So one of your goals is to focus on what is there now and what can be added to. Next slide, please. So here's just kind of a graphic. Your people will draw this themselves, put themselves in the middle of the map, or you can help them draw it if they have trouble drawing. And then around them, it's kind of like a diagram of an atom or a solar system. They can put in bowls for all the people, and you know, if they want, they can do it in color. They can have fun with it. They can put the good friends on bigger bowls and people that they have less contact with more distantly, however they'd like to do it. But you can see here that there are many different categories of people that we need to consider as connections, not only the usual suspects like family members, sisters, sons, nieces, but also, you know, the community centers. There can be the pets that they have. The caregivers are important. Sources of support. Nurses and doctors are important sources of support. Church groups, neighbors, and also all the telephone, and in the COVID crisis, the Zoom and, you know, Skype contacts. So you're going to help them make their own customized map according to, you know, what they have going for themselves right now. Next slide, please. And then once they've developed this thing, you want to have kind of an open-ended, flexible conversation with them. And here's a list of the kind of thoughts you're going to have in your mind and questions you can ask. And you do this based on your relationship and your understanding of the person. But which connections are most important? Who, you know, people get different things out of social support. You know, some people give good advice. Some people just make you laugh. And you do fun things with. Some people you can share your personal secrets with and get a lot of feedback and talk about what's going on with you, what's stressing you out. And who do you want to spend more time with, and who do you want to spend less time with? Some people are sources of aggravation and bring you down, and maybe you want to change that. Are there old relationships you want to improve or reestablish or deepen? Who might need your help and support? How do you want to help others? And also think about, you know, animals, organizations. Next slide. And then after this conversation, you can have this conversation, you know, according to your own judgment. Then you want to just get action oriented and have a person make a plan. Particularly, you want to identify one or two things that people want to do to change that network. Maybe it's somebody a new person they want to call. Maybe it's somebody they want to ring up and they want to experience opening up more to that person. Maybe there's a new social activity that they'd like to try that they haven't done before. And you want to agree the actions they're going to take before you circle back with them next time. And, you know, make sure that they understand the plan and that it makes sense to them and they're down with it. They want to follow through. And, you know, if they need assistance in making the contacts or any of that, you might want to explore whether you need to do that, get on the phone with them and join in and make those changes easier for them to accomplish. Next slide, please. And, you know, all of these things, this skill and the positive activity skill I'm going to be talking about next, they're cumulative. They're not one-offs. The way that this enhanced social support has its impact on you is by doing it over time. It's not like you just have a good week and you talk to a couple of people. That's good. But it's by deepening and making more frequent and more useful your social contacts with people, that you, in the long run, perform the recovery function of these activities, as well as the preventive function in making people less likely to fall back into depression or less likely to revert to excessive alcohol use. So you want to build in kind of tweaking this and revisiting it and looking back at that map and seeing what's working and building and developing and trying new things. So, you might have had the person doing this or trying something, a month and a half later or 3 months later, there might be something new that they want to try. And you want to build that into the ongoing dialogue with the person and be making sure that they're servicing those relationships and deepening and broadening them in an ongoing way. Next slide, please. So we also find that depression is a real big one, right? Whereas building social supports is helpful for whatever is ailing you in life, for all of the different kinds of stressors or worries that a person may have. Building mood and positive activities is not quite as broad, but it's also very important because, people feel good when they have things that they enjoy doing. They're more likely to feel good. And, activities help the person feel less sad, hopeless, fearful, or low in energy. They help the person feel more in control and that there's something to live for. Life is rewarding. They build a sense of meaning and purpose. And many of these are social in nature. Next slide, please. So building and increasing participation in positive activities is typically called behavioral activation in the lingo. And it turns out it is an evidence-based intervention for depression. And especially maps on to older adults because of the diminishment in the opportunity to perform meaningful roles and to participate in sources of enjoyment that happen as people move into advanced old age. You can't do the tennis that you used to play. You're not as mobile. You can't get places and go see people. Sometimes when people are also under stress, they feel they're too busy dealing with their problems. So they cut back on positive activities, or they feel depressed and down so much. When you feel depressed and down, you say, I'm not going to go out and do that. I wouldn't like it. So your depression interferes with your ability to access and your motivation to go out and do things. Sometimes if somebody has experienced the loss of a spouse, for example, sometimes, our exhortations to go out and get involved in positive activities can seem trivial and unimportant and insensitive. So we want to be aware of that. And obviously with the COVID, it's hard to be involved in positive activities in some way. But again, if you no longer engage in rewarding or meaningful activities, you're bound to begin to experience negative mood and depression. Next slide, please. So again, we break this down into 3 simple steps. Explain the rationale first, because you got to get a person on board. But then generate a list of possible activities, help the person select 1 or 2 or 3 that they want to do, identify and plan, get concrete, plan for them to do those things, and then schedule it with them. Agree when and where they're going to do it, and then you're follow up and review. Next slide, please. So again, I want to make a point about this one. In my work I have a clinic, for example, for recent trauma survivors, and we often get people who have experienced traumatic bereavement. Their loved ones have committed suicide, for example, or been murdered. Lost the slide there. Is the slide still there? Can other people see the slide? Okay, great. So the thing is that if a person is going through something extremely emotional, this could be true of the older adults that you're all working with, we need to make sure that we're not, accidentally seeming to trivialize the person's need or be insensitive to the very grave problems they may face. If, for example, if they have a terminal illness. So we want to be thoughtful on how we describe the role in this. The first thing I would say is that we should introduce positive activity scheduling only after we've made sure we have clearly done things to address the core needs of the person. Then this positive activity scheduling is an adjunct that can literally be valuable for anyone, because even if you have a terminal illness or have lost your spouse of 50 years, finding ways to be involved in activities that are meaningful to you, that you value, that can bring you more calm or better feelings inside yourself are tremendously important in influencing mood. So you want to make clear that you're supplementing the other things you're doing, and that it's often valuable to also introduce it as an experiment. Let's try it. Let's see if it is helpful to you, because if we can lift your energy and lift your mood, then it's going to help you with all the other things that you want to focus on in your life. Next slide, please. So brainstorming positive activities you want to do, sometimes this is hard for a person. So for example, in the SPR manual that I described, and in other places you can find, there are long lists of activities that you can review with a person. It gives them lots of ideas, because, you know, oftentimes if you ask a person, they won't come up with very much. But if you give them a list, they'll see, oh, well, there's a whole lot of things that can do this. So review a kind of a manual list with people, and then brainstorm with them about which ones they might want, and have them, encourage them to pick 1 or 2 or 3 activities that they would start doing in the next week or 2. And it can be activities that are fun and enjoyable, but it can also be ones that enhance sense of safety, that make them feel closer to people they care about. They can be social activities. They can be activities that are calming and relaxing, kind of harking back to what Joan has said. They can be distracting activities that help you for a little while, just get a benevolent distraction from your worries. They can be things that help you move your body and are exercise. They can be things that reconnect you with your personal skills and competencies. I'm retired now. I'm still involved in the field. I'm not earning money for it, but it's a way I can exhibit my skill and my passion. And you can also contribute to the well-being of others and fulfill a sense of purpose. All of those things are what we mean by positive activities. Next slide, please. So you want to select those activities. I've said you want to kind of boil it down to 1, 2, or 3 that the person has some mojo for, they're motivated by. And so that is 1, things that people think they might enjoy. 2, things they think that they would actually do that are achievable for them. Because, you know, some activities you've been wanting to do for a long time, but you don't get around to it because for some reason it's too much hassle to do it. You know, maybe you want, you know, you like the bike ride, but I need to get the bike down out of the garage. And geez, I don't know if it's in working order. And also things that they can set up fairly easily. You might know that you want to go, you know, to see the Eiffel Tower, but and would that lift your mood? Yes, it would. But that's not practical and easy. You want to identify things that people can really do right away. And sometimes that could be simple, you know, as I worked with one recent trauma survivor. She was a single mom, and she was overwhelmed with her job and her recent loss, and also had, you know, 2 kids that were driving her crazy. She didn't have a minute to spare, but she loved, after getting the kids, to set up a really beautiful bubble bath with, you know, salts and things in the water that made her feel great about herself. And she put some candles by it, and, you know, she could do that. It was easy. It just took 15 minutes, but it helped. Next slide, please. So you also need to get down and dirty and schedule these things, because people who are depressed and down, you know, when the time comes to do the activity, they go, oh, I'm too tired, I don't have the energy. So, you know, scheduling things and working out when people are going to do things is important. If people have a calendar, you put it in a calendar. If our older adults have jettisoned calendars now in retirement, like I actually have one, but I don't, yeah. But you get the idea. So you want to just get concrete about when they're going to do it. And you can also talk about obstacles if you want to anticipate obstacles and how they plan for those. Next slide, please. And so then you want to review these activities. I've already said that. I want to get to questions. So next slide. Note that in the pandemic, we have to be more creative about this. We have to do a lot of activities virtually. You know, we also have to do it with distancing. Next slide. So today I've just talked about these 3 tools, you know, trying to get clear on what you think are the precise things that a person is self-medicating, so you can match your coping tools to that, and then increasing social contacts and participating in positive activities with these pragmatic tools. Again, go back to the manual, download these things. You'll find them very helpful in the COVID pandemic. Next slide, please. That's the end of mine, and so hope I haven't run over too much. Looking forward to hearing your questions now.
At this point, I'd like to turn the microphone over to my colleague, Dr. Barbara Bedney, who's going to read some of the questions that we've received.
And I'll start by thanking you both for some amazing presentations and for some amazing conversation and information. We do have a bunch of questions. I will sort of, I guess, maybe go back and forth and see how many we can get through. First question looked like it was for Dr. Cuck, and the question is, do older adults need less sleep, and do cognitive behavioral therapy interventions take that into account?
Hi, I answered most people's, I think, questions.
You did, okay.
Just now, but I could do that again. And also just a shout out, I know all of you are experts in the field, and some of you asked me questions are like people whose articles I've read, like Lori Daniels and Amber Gum. So thanks for coming to the presentation and recognize that you could be there too. So the answer to that question for everybody that didn't hear it is, do older adults need less sleep? And I think that was a myth that we thought in the field, but actually all the research that I have read and the clinical guidelines say that older adults need just as much sleep as younger adults, typically 7 to 9 hours a night. Sorry to be long-winded, Barbara.
And one more question we have here is, if there's an underlying sleep condition, I know you mentioned some of those, do the suggestions that you were talking about help if those conditions are there?
Yeah, I would think of them then more as sort of supplemental, and that we need to treat those disorders, which is why people like me who are PhDs or non-prescribing providers need to work with a team of people that could intervene on some of those. And there was also a question that I got several times about over-the-counter medications. And, you know, I'm a non-prescribing person. My understanding of the literature, and I do know it, but I don't feel as comfortable sort of making statements, since this is not my main area of expertise and credentialing, is that melatonin is effective, that it comes over the counter in 0.3, 0.5, and then I think 3 and 5 milligrams, and that 0.3 milligrams is just effective as the higher ones. Yeah, and that the higher ones are no less effective as 0.3.
So we have a question, I guess, either one, maybe Dr. Rizek. Are there strategies to help older adults who have ingrained negative beliefs about themselves, for example, who've experienced chronic child abuse or things like that? I guess for either one of you.
Well, Joan, I'm sure we're thinking of some of the same things. The most useful approach would be to get people involved in one of the variants of cognitive therapy. You know, big one for us in PTSD is cognitive processing therapy, developed by Patricia Resick, R-E-S-I-C-K. If you haven't read the manual on CPT, I really recommend it, because it's one of the very best tools for all of us who work with trauma survivors, because it has tons of examples of how to explain concepts, of things to do. It's very pragmatic. But there are a lot of different kinds of, quote, thinking errors or negative thoughts or stuck points or distressing beliefs that trauma survivors very likely have. In fact, there's a whole inventory called the post-traumatic cognitions inventory that measures those things. But so surfacing and discussing and opening up those negative beliefs for conversation is valuable. But if it's very ingrained, like you're kind of suggesting with a conversation, ideally you would find either yourself learn about these tools, or find a colleague practitioner in your region who might be able to do it, because the cognitive processing therapy is really very effective, and it's a 12-session psychotherapy which focuses on negative beliefs, and it is very, very good, but very detailed and systematic about doing that. So you know, it's a very important thing, because a lot of distress and a lot of PTSD symptoms are driven by negative beliefs that are ingrained for a long time.
So just to piggyback on that, I love CPT, and I think as a, you know, I feel like I'm a lifelong learner. I put lots of different things in my toolbox, and therefore I have lots of different things to choose from to help the people that I work with. I was trained by Edna Foa, who developed PE, so I tend to say, that I'm more of a PE person than a CPT person, although it's valuable and I like it. But so I've written several papers with my colleagues Stephen Thorpe and Alyssa McCarthy on how to apply PE to a range of older adult trauma survivors. I have a book chapter I'm working with a 9/11 survivor, I have a combat veteran, and we have an older male sexual abuse survivor. So if you want any of those papers, ask Barbara or email me directly and I'll send it to you. I think sometimes when you're working with someone, I think this was a question from Amber, so you could probably answer this as well as I can, the question that you asked, but I think sometimes with older survivors, when they've worn the diagnosis for so long and it's been so severe, it becomes sort of second nature, almost like a personality thing. Sometimes you don't see that reduction in the frequency or in the intensity of that thought, but you get that it comes up, but the distress doesn't cause them as much. They go, hey, I know where this comes from. So it's not like we're changing their thought, but we're again getting our sort of foot in the door so that they can question it and say like, there, I know where this comes from. This is old stuff. This is not true. It's still going to come up for me, but I'm gonna be less distressed when it does, because I'm going to know that it's not true. Yeah.
Yeah, and I think that that's right. You know, part of the psychoeducation that happens with both prolonged exposure PE and cognitive processing therapy, or CPT, is psychoeducation about the role of distressing thoughts. And it enables people to step back from those, and it doesn't have quite as much power over them when you start to realize, oh, this is not the way the world is. This is an interpretation or a judgment that I'm bringing to this by virtue of being a trauma survivor and all the things that happened to me. By the way, I just want to, if Lori Daniels is on the call, it sounds like Joan Cook knows that. I just want to give a shout out to Lori Daniels. She's an old friend. I haven't talked to her in years, but hi Lori, if you're here somewhere. The other thing I wanted to say is that I realize that most practitioners haven't learned prolonged exposure or cognitive processing therapy because the training for those has not been embedded in our professional training programs, and it's rather difficult to find ways of learning them once you are a seasoned professional. But the Medical University of South Carolina, MUSC, has free online trainings in both PE and CPT. They're each 10 hours in duration, and more than 100,000 people have taken these trainings. So if you want to go learn more about them, they're very hands-on. They're done. They were made by the developers of the interventions, and they have videos of it, and they're really very good. So just a resource you might use. So the person who asked a question about these negative beliefs, you know, go check out the CPT thing. It'll give you tons of great ideas.
So I think we hopefully have time for one more. There was a question about apps, and how do you encourage older adults to use apps, and how do they feel using apps, and is it, you know, just how do you get them to use those kind of tools?
So I could share what I do clinically. I guess maybe I haven't had that problem as much, and as the person posing the question, but I think I would present it with them and do it with them in session, and bring it up every time and practice with them so they got used to it, and sort of I start doing it and then sort of hand it to them to start doing it. But the way I sort of said it in my response is, for the people that I work with, I talk about, you know, PTSD takes away your power. And I think part of PTSD treatment is taking back your power. And so I try to encourage people, every little positive, safe sort of strategy to sort of learn and try is a step towards taking back your power. So I would sort of frame it like that if they were sort of less curious and hesitant. But I will let the digital technology guru, Joe, add in what you guys do, because you do this all over the world, digital technology for treatment of trauma.
Well, I think what you've just said is very sensible. I would just add to that, you know, take a look at these apps yourself, download them on your own phone and noodle around with them so you know what they are and what's in them, because all the evidence with apps and with internet interventions is that guided self-help works better than unguided self-help. In other words, if you just say, hey, check this thing out, go use it, and you don't integrate it into your therapeutic conversations and follow up and enrich it, people are unlikely to get a therapeutic dose. They might go to it and drop out. So you talking with them about it in an ongoing way will increase their use of it, because I think they're great. You know, they really are empowering tools, like Joan is saying. The other thing I'd say is, you know, you're going to encounter older adults, many older adults now with phones. Phones are ubiquitous, so older adults are using phones. If they are less familiar with apps, then you want to help them actually download the app on their phone. Help them download the app and then sit with them, like Joan is saying. You know, open it up, show them how to open it up, give them practice in opening it up, and then noodle around with them in it. So, you know, help them get familiar and then talk about how they might use it. I'm a fan of actually giving them an assignment, you know, a kind of homework assignment. Hey, I'd like you to just check out this feature on this app next week. Would you be willing to do it? And then we'll come in and talk about it. So my colleagues and I developed a 2-hour and a 9-hour training for psychologists on integrating digital technology into care. If you want to check it out, go to APA, American Psychological Association. You should be able to find it there. It has CEUs, so it's also something you could check out. But good question. But by and large, these things are super cool. Apps like Calm, for example, you know, some of them are commercial, but you can get basic things. They're just beautifully produced, and they like that. The app CBTI Coach that Joan talked about. If you're working with someone on sleep, you really should use this, because it's a lovely supplement.
Yeah, and the great thing is too, a lot of these are free. Not all, but a lot of them are free. So. Well,
all the ones that we develop, like PTSD Coach and CBTI Coach, courtesy of the U.S. government, Department of Veterans Affairs, are all completely free.
And now they have COVID Coach.
Yes, they do.
Yeah. Free.
I want to thank you both for presenting, Dr. Ruzek and Dr. Cook. I am really grateful for the guidance and tips and tools. It's really, we walked away with something that we can actually apply. And I'm impressed. We still have 215 participants that have hung out to the very end. And so if you still have questions, we will try to respond to them. We see them in the chat box. We will try to follow up with you. You will get a recording of this webinar, and you will get the PowerPoint as well. Next slide, please. So I want you to look out for that. And also, we encourage you to please complete the evaluation at the end of this so that we can always improve our webinars. We offer, I think it's been about one a month or one every other month for this entire year. So we really welcome your feedback, and we will change the topics and consider the speakers based on the feedback that you provide us. For our current subgrantees, we must, to verify your participation in this, the secret word is sleep for that. Next slide, please. If you have any questions, Dr. Cook or Dr. Ruzek, you're welcome to write us at the holocaust.center@jewishfederations.org, and we will gladly track down the doctors and ask them to answer our questions. So we're happy to follow up with you at that. I encourage you to look for more information about trauma-informed care and older adults on our website at holocaustsurvivorcare.org. Before I sign off, Dr. Ruzek or Dr. Cook, is there anything else you want to add?
No, thank you for having us. I love your organization. You are indeed the squad, and I'm so glad for the work that you do. Thanks for always including me.
Yeah, and thank you for the invitation to join Joan and present to you. And we do hope that there are some tips in here and practical tools that you can use. And please do go and download the stuff that I told you about. You'll find it very helpful. And good luck in your fine work with older adults who are trauma survivors.
Oh, I have something to add. So I remember a number of years ago going to what a lot of us go to, the International Society for Traumatic Stress Studies meeting. And Janet Reno was a speaker that year. Joe, I don't know if you remember this. I think it was down in Miami. And she said, you know, thank you. You're doing the work of angels. And so I just want to say that to all of our participants. Thank you. You are doing the work of angels. Thank you.
I think that's a great note to end on. Thank you all for joining us today for the Jewish Federations of North America's Center for Advancing Holocaust Survivor Care webinar. And thank you again to our guest speakers, Dr. Ruzic and Dr. Cook. Stay tuned for the next one.
Bye, Joe.